Great. So I'll go ahead and get started. So thank you very much for the introduction and having me come and speaking. I'm planning on talking about a topic that's very near and dear to my heart, which is colon cancer screening and kind of really focusing on quality improvement. Here are my disclosures. So my goal in the next 45 minutes or so is to do the following things. Number one, I want to talk a little bit about current options and recommendations for colorectal cancer screening. And then I want to talk a little bit in detail about the recent issues with the increase in young onset colon cancer and the US Preventive Task Force Services recommendation to begin screening at 45 versus 50. And we'll talk about the pros and cons to that. And then I wanted to focus on a colonoscopy and review some quality metrics, which I think may be pertinent for some of you to understand, which focuses on the kind of the limitations of colonoscopy. So let me start off by kind of just reviewing the fact that colorectal cancer screening is working. As we can see, the incidence overall and the mortality from colorectal cancer has decreased over the years. And if we look at kind of focusing on beyond 1990, we can see that there does seem to be an effect of colon cancer screening in terms of driving down the incidence of new colon cancer as well as colon cancer mortality. Now, all of you, I am sure, have read the news, which has really demonstrated that there does seem to be an increase in young onset colon cancer. And if we look at the graph to the left, we can see an uptick in the incidence of colon cancer for those under 50, a kind of striking increase in actually patients who are 30 to 39 or 20 to 29. And this is concerning. But when we zoom out, if we look at the graph on the right, we can see that even though that those rates are increasing for young onset patients, overall, the incidence does appear to be decreasing for the majority of patients. And this is likely secondary to screening as well as improvements in kind of treatment options for patients with colon cancer. So I want to spend the next several slides reviewing the top tier options for colon cancer screening. So I'm focusing on the GI Multi-Society Task Force recommendations, which were published in 2017. And it really breaks down what the top tier and lower tier options are for colon cancer screening. And then we'll go into detail about each of these. So the tier 1 recommendations for colon cancer screening are performing a colonoscopy every 10 years if the colonoscopy is normal with an adequate bowel preparation, as well as annual fecal immunochemical testing or annual FIT testing. So those are really considered the top tier options. For patients who do not want to have either a colonoscopy or a FIT test done annually, the second tier options can include a CT colonography to be performed every 5 years, FIT fecal DNA testing, which is also known as Cologuard, every 3 years. Excuse me, that should be years, not days. And then FlexSig. So we'll talk a little bit about these options in a little bit more detail. So colonoscopy tends to be the preferred screening test for us. Obviously, we're biased because we perform colonoscopy, but colonoscopy has several advantages in that it is the only test which can detect and remove precancerous lesions. Compared to the other tests, it really has highest sensitivity in detecting colon cancer as well as precancerous adenomatous polyps, which can turn into cancer over the span of several years. And in fact, 1 or 2 negative colonoscopies really does seem to lead to kind of long-term lifetime colorectal cancer protection. The other benefit is that patients can go long intervals between normal examinations. So if a colonoscopy is normal, they can go a full 10 years before their next screening examination. And although there has yet to be randomized controlled trial evidence supporting colonoscopy over FIT testing, there is several cohort studies that have shown efficacy in colonoscopy in preventing future colorectal cancer. However, the disadvantages are real. I mean, this is an invasive procedure and there are risks of the procedure, particularly in older patients who have significant comorbidities. So the procedural risks include perforation, which can occur secondary to polyps being removed or can occur on its own. The other main limitation of colonoscopy is that it requires a bowel preparation, and it turns out that a complete effective bowel prep is the most important determinant to the success of a colonoscopy. Without an adequate bowel preparation, there really is a limited benefit of colonoscopy. And in fact, performing a colonoscopy with an inadequate bowel prep can increase the risk of future post-colonoscopy colon cancer. Um, the third point is that colonoscopy is unfortunately a very operator dependent test, which is something that is not ideal for a screening test that's recommended for the entire population. And in fact, the performance of the GI endoscopist really matters in terms of the benefit that can be achieved in terms of reducing colorectal cancer. So annual fit testing, the advantages are, well, it's cheap, it's non-invasive, it doesn't require bowel preparation. The one-time sensitivity for colon cancer for a one-time fit test is not great, but it's about 80%, and that number can increase when you do the test annually. And it's a reasonable option for patients who are not interested in colonoscopy because they prefer not to have an invasive procedure. However, the disadvantages are that it really has limited sensitivity for polyps, particularly advanced polyps, which are the lesions that can grow over time into colon cancers. This is something that needs to be repeated annually, and a positive test needs to be followed by a timely colonoscopy in order to potentially detect and remove advanced polyps that can turn into colon cancer. The other thing that the fit testing is not very good at, it's really limited sensitivity for detecting serrated polyps, which we are recognizing is an increasingly frequent cause of colon cancer. So those are the two top tier options. The second tier options include fit fecal DNA testing. So fit fecal DNA is basically combining the fecal immunochemical testing for hemoglobin with stool DNA markers. And by kind of merging the fecal DNA with the stool fit, it actually increases the sensitivity for colon cancer up to about 90%. And as a result of this, the intervals for Cologuard or fit fecal DNA can be spaced out to every 3 years. The disadvantages are that it's significantly more expensive than stool fit testing, and the specificity is lower. So what ends up happening is that there are a lot of false positive results that that require a follow-up colonoscopy to exclude the presence of colon cancer. In the past, there was uncertainty about what we should do with patients who have a positive Cologuard and a subsequent negative colonoscopy, and whether we need to pursue additional workup. There's been plenty of evidence that suggests that the risks of upper GI cancer is extremely low in those cases. So for people who have a negative colonoscopy after a positive Cologuard, there really isn't any recommended further workup. CT colonography or virtual colonoscopy is also considered a second line option for colon cancer screening. The advantages are that it is obviously not an invasive procedure. It can detect polyps that are over 1 centimeter in size relatively well, and those are the polyps that typically do go on to become invasive down the road. The disadvantages of CT colonography are that it still requires bowel prep, so you can't get away from that bowel preparation. It's deficient in detecting smaller polyps, flatter polyps, and serrated polyps, which again, as I mentioned, are increasingly a cause of colon cancer. And then, we often find a variety of incidental extracolonic findings that require workup, and certainly any small polyp that's found, or any polyp that's greater than 5 millimeters that's found on CT colonography, does require a colonoscopy ultimately for removal of those polyps. So those are the screening options. I didn't mention flexible sigmoidoscopy because it's really not, as of 2020, considered a recommended option for colon cancer screening, because it only detects the left side of the colon and doesn't look at the right side of the colon. Okay, well, I want to talk a little bit about age, and I'll focus on the current GI Multi-Society Task Force recommendations. We'll talk about the US Preventive Task Force Service recommendations shortly. But based on the GI Multi-Society Task Force recommendations, which is what we tend to follow in our GI practice, screening should begin at age 50 for patients who are average risk for colon cancer. However, we should consider doing screening earlier in patients with colorectal symptoms, such as rectal bleeding or iron deficiency anemia. Um, Now, the one key to remember is that it's really important that we take an accurate family history to determine a patient's risk. And so for patients who have a family history of colon cancer or an advanced adenoma, and we'll talk about what that means, in two first degree relatives at any age, or in one first degree relative less than 60, we recommend starting screening at age 40 or 10 years before the youngest age of diagnosis of the affected relative with a colonoscopy. And that colonoscopy is recommended every 5 years. An advanced adenoma is considered an adenomatous polyp, which is greater than 1 centimeter in size, or a polyp that contains villus or tubulovillus features. And those are treated the same as colon cancer because those advanced adenomas are ultimately the polyps that actually carry increased risk of turning into colon cancer. So, for patients with a family history who just have one first degree relative with someone with colon cancer or an advanced adenoma, then we still recommend beginning screening at age 40. However, the options for screening are the same as an average risk person. So you can consider either FIT or colonoscopy. And if the colonoscopy is normal, then you can do it every 10 years, but it begins at age 40. Um, so race is also an important consideration of when we begin screening. And what we can see here, this was a cohort study comparing kind of the incidence rates of colon cancer depending on age, comparing kind of white Caucasian colons versus African American patients who undergo colonoscopy. And what was found is that African Americans tend to have overall higher incidence rates of colon cancer, as well as an earlier mean age of onset of colon cancer. And so based on these recommendations, based on these data, there's recommendations that suggest that we should probably screen African Americans beginning at age 45. Now, this is a conditional recommendation based on very low quality evidence, but that is what was recommended by the Multi-Society Task Force previously. The task force also recommended stopping screening in patients who are 75 or older for patients who've had prior screening examinations with negative screening tests. So consider stopping at age 75 or when the life expectancy is less than 10 years. However, patients who've never been screened before can be considered for a first-time screening with a colonoscopy up to age 85, but it depends on their age, their comorbidities, and their expected lifespan. So let's focus on the recent recommendations on decreasing the screening age. And we've seen a lot of recent media on the increasing rise of colon cancers in young people. So the American Cancer Society actually took a bold recommendation in 2018 and actually suggested recommending screening everybody at age 45 for all average risk patients with either a FIT or a colonoscopy. This was basically based on not a randomized controlled trial or a cohort study, but it was based on a microsimulation modeling study, which compared starting screening at age 45 versus starting screening at age 50. And what the microsimulation study found is that starting screening at age 45 led to more life years gained. However, that led to significantly higher numbers of overall colonoscopy being performed. So there were a lot of concerns when these recommendations were published 2 years ago, in that we might be encouraging screening in a lower risk group when we don't even sufficiently screen our higher risk group. So after this was just published in the last month. The US Preventive Task Force Services made new recommendations for screening and specifically recommended screening patients at age 45. So this was a new recommendation where they recommended screening at age 45 to 49 with moderate certainty. So this was a grade B recommendation. Starting screening at age 50 was still a grade A recommendation and was recommended with high certainty. And for patients over 76, you can consider screening, but that decision must be individualized. So this is certainly new. If we think about, well, what are the pros and cons of starting screening at age 45? Well, clearly there is an increase in the incidence of young onset colon cancer. And the goal of starting screening in everyone in age 45 is to prevent colon cancer in this group, and to, hopefully by screening everyone at 45 or increasing screening in the greater than 50-year group. However, there are lots of concerns and about potential consequences of this approach. So if we kind of divert our limited resources to patients who are 45, some of whom may be lower risk for colon cancer based on their comorbidities, based on their demographics, then we're really potentially increasing our screening disparities by not screening patients who are over 50 who are higher risk for colon cancer. This approach also may substantially increase overall costs. And also, there's really limited data on what the right test is in the younger population. Should we be doing colonoscopy? Should we be doing FIT testing in patients who are 45 to 49? We simply don't really know. So, these are kind of my thoughts on what our ideal course of action should be. I still think that we should be really focusing our efforts on screening as many patients who are over 50 as possible. We should be screening African American patients starting at age 45 based on the fact that the incidence overall does seem to be higher and the age of onset seems to be lower in African American patients compared to other races. And I think that we need to be doing a better job in focusing on the uptake of family history. So patients with a family history of colon cancer or an advanced adenoma should be screened earlier. And then finally, we should have a low threshold to perform colonoscopy in younger patients with any symptoms, whether it's rectal bleeding, whether it's iron deficiency anemia, unexplained change in bowel habits, or abdominal pain, just because many patients who are in their 30s and 40s can often present with the distal colon cancer at a young age, and they usually present with symptoms. Ideally, we would have some sort of risk stratification to determine what patients who are 50 or 45 might benefit from screening, but unfortunately, we don't really have that yet. So let me pause there, and I'll just pause for a second to see if there's any questions. Otherwise, I'll move on. Any questions about kind of recommended screening options before we talk about colonoscopy? Okay, I'll take that as a no. So I can move on. Sorry about that. So I have a variety of pictures here of polyps that I've detected over the last few years at the University of Chicago. So I wanted to take this section and talk about colonoscopy and talking about colonoscopy quality. And the reason that assessing colonoscopy quality is important is because a lot of you all order colonoscopy, and I think it's important to recognize that the colonoscopy is unfortunately not a perfect test. And the reason is because polyps in the colon, which we think are the lesions that can grow into colon cancer over time, polyps are missed because this is an operator-dependent procedure. And I'll show you some data about how frequently polyps are missed. The second point is that polyps, even when they're detected, are often incompletely resected by GI endoscopists. And the third point is that patients are often given inappropriate surveillance recommendations. And what ends up happening is that patients who are often found to have a high-risk lesion, whether it's a large polyp, are often not brought back in soon enough, and this can lead to a future interval cancer. The converse is also true. We often overutilize colonoscopy in very low-risk patients. For example, patients who have very small polyps, we often bring them back every few years. And this really leads to high costs with limited benefit in terms of reducing the incidence of colon cancer. So talking about missed polyps and the frequency, so there have been several tandem colonoscopy studies done to determine how frequently polyps are missed. This was a meta-analysis basically looking at all published tandem colonoscopy studies. Tandem colonoscopy study is when a patient undergoes a colonoscopy, all visible polyps are detected and removed, and then a different endoscopist goes in the same day and repeats the colonoscopy. And I wanted to stress how kind of staggering these numbers are. And so what was found is that an adenoma, which is any kind of precancerous polyp, is missed 26% of the time. And in fact, an advanced adenoma, which are the lesions that directly increase the risk of colon cancer, can be missed 9% of the time. This is concerning, given this is concerning for a screening test that's performed and recommended in all patients. Factors that really increase the risk of missing the polyp include size. So smaller polyps can be missed up to 28% of the time. And actually location matters a lot. So what we see here is that polyps in the cecum and in the right colon can be missed 17% of the time. And these miss rates are directly associated with the bowel preparation. So this is concerning given the fact that polyps are missed that frequently. My second point was that I mentioned that polyps are often incompletely resected. So the CARE study was a study that was performed where investigators took marginal biopsies at the site of a polyp, where after the polyp was removed, investigators then took small biopsies around the post-polypectomy site. And what they found was that incomplete resection was identified in up to 10% of all resections. So microscopic adenomatous tissue was detected up to 10% of the time after polypectomy. And these rates of incomplete resection went up significantly for larger polyps. So for polyps that were 10 to 20 millimeters in size, incomplete resection was found in 17% of the time. Sessile serrated polyps, I mentioned serrated polyps are increasingly a cause of colon cancer. Incomplete resection was found 31% of the time when sessile serrated polyps were removed. And so this is concerning and potentially an explanation for why some patients can develop colon cancer despite having a colonoscopy with polyp removal. Inappropriate surveillance is also very common. So I mentioned that inappropriate early surveillance is common. However, inappropriate late surveillance is also common. So this was a study looking at the adherence to recommended surveillance intervals dependent on what was found at the time of colonoscopy. And in this individual study, inappropriate surveillance was found in 89% of patients who had a colonoscopy, both patients getting inappropriate early surveillance as well as inappropriate delayed surveillance. So really determining when the appropriate surveillance should be done is an important factor. There's been a lot of literature in patients who have low risk polyps and increasing data on the fact that patients who have very small polyps are probably not at increased risk for colon cancer. So this was a study published in JAMA a couple years ago where they looked at patients who underwent a colonoscopy and were found to have either no adenomas, a non-advanced adenoma, which means an adenoma less than a centimeter in size, versus an advanced adenoma. And what we can see is that ultimately the patients who were found to have an advanced adenoma were the patients who did have an increased risk of future colorectal cancer. Interestingly, patients who had no adenoma, as well as patients who had a non-advanced adenoma, their risk was very similar, so similarly low. So overall, this suggests that ultimately patients who have advanced adenomas are likely the ones who have increased risk of colon cancer, whereas non-advanced adenomas probably don't increase the risk. This was a similar study done in the VA population where vets who had undergone colonoscopy with at least one surveillance examination were included. And so what they found was that patients who had a baseline colonoscopy with 1 to 2 small adenomas overall had a 6.3% chance of having a future advanced neoplastic lesion, which was not significantly different for patients who had a normal examination. So ultimately, the only factor that really increased the risk of future advanced neoplasia was having a baseline advanced adenomatous polyp. Having multiple adenomatous polyps also increased the risk of future advanced neoplasia. But again, this suggests that overall non-advanced polyps or small one to two small polyps really likely does not increase an individual's risk for future colon cancer. So based on this, as well as a few other studies, there were recent recommendations by the GI clinical guidelines to change our surveillance recommendations. In the past, we would recommend repeating a colonoscopy in 5 years with the detection of any adenomatous polyps. However, in light of the fact that non-advanced polyps are unlikely to increase the risk of colon cancer, the most recent guidelines suggest spacing out the recommendation. So for patients who have a normal colonoscopy, the recommendation is still to perform a repeat colonoscopy in 10 years. For patients with 1 to 2 small adenomas, instead of doing it at 5 years, the new recommendation is to repeat a colonoscopy in 7 to 10 years. And similarly, the recommended intervals for patients who have 3 to 4 adenomas was also spaced out. Now, the reason we're talking about colonoscopy quality and why that's important to kind of recognize is that unfortunately, post-colonoscopy colon cancer is relatively common. In fact, 8% of all new colon cancers are categorized as a post-colonoscopy colon cancer. So that means that patient had a colonoscopy that was adequate and subsequently developed a colon cancer within the time frame that they were told to come back in for a follow-up. So 8% is relatively high when we think about it. We think about colonoscopy being a screening test. We should assume that it's going to be effective in preventing colon cancer, but unfortunately, it's not perfect for the reasons that I've already mentioned. So let me just pause here and go over a case. So this was a real case that that I detected probably a couple months ago. So this is a 55-year-old man who presents for a surveillance colonoscopy. They had a colonoscopy 3 years ago that was notable for a fair bowel preparation with liquid brown stool in regions of the right colon. Their colonoscopy today is notable for this ulcerated lesion in the cecum, and I take biopsies and it confirms evidence of invasive adenocarcinoma. So this would be categorized as a post-colonoscopy colon cancer because they had a colonoscopy and then subsequently developed a colon cancer. The question is, well, was this lesion there 3 years ago, or was it a new lesion? And so I bring up this case to highlight a couple factors. So the first is that an individual endoscopist's volume as well as their adenoma detection rate, and we'll talk about that in a minute, really are the main determinants for how frequently an individual endoscopist will have a post-colonoscopy colon cancer. So it turns out that for an individual endoscopist, the higher the rate of detecting polyps. So adenoma detection rate is essentially how frequently an endoscopist detects an adenomatous an adenomatous polyp. And so an individual endoscopist, if their adenoma detection rate is higher, overall, their risk of developing post-colonoscopy colon cancer is lower. So what we can see here is, if we look at the graph on the bottom, the y-axis indicates the number of years for an endoscopist to detect one interval colon cancer. And as we can see, as their ADR goes up, it takes many more years for an individual endoscopist to experience a post-colonoscopy colon cancer. The other factor that's important is volume. So obviously, the more colonoscopies that are performed, the higher likelihood that an endoscopist is going to develop a post-colonoscopy colon cancer. So let me talk about the current recommended priority quality indicators for colonoscopy. The first one is the frequency with which colonoscopies follow a recommended post-polypectomy surveillance and 10-year intervals between screening colonoscopies in average risk patients. So the goal is that we should be really appropriately recommending surveillance intervals for patients who have an average risk, who have normal colonoscopies. We should be recommending a surveillance in 10 years and not sooner than that. The other priority quality metric is the cecal intubation rate, which is the frequency with which visualization of the cecum by notation of landmarks is documented in every procedure. And then the third is the only outcome measure, and that's the adenoma detection rate, which I already mentioned. So as I discussed, it's the frequency with which adenomas are detected in asymptomatic average risk patients. Now, the standard recommended QI metrics are that overall, 25% of the time an adenoma should be detected. So an individual's ADR should be at least 25%. It should be higher in males and at least 30% in males and 20% of females. There have been a variety of other QI metrics that have been proposed. So for patients immediately prior to the procedure, bowel preparation frequency is considered another potential QI metric. So as a system, we recommend that at least 90% of the time when we're doing a colonoscopy, the bowel preparation should be adequate. If it's not up to par, if you're less than 90%, that means that the system as a whole is not performing as it should. In terms of the procedural completeness, cecal intubation should be happening at least 90% of patients. If it's not happening, then that can be concerned that the complete colonoscopy is not being performed. As I mentioned, adenoma detection rate is considered a priority quality metric. And again, 25 to 30% of the time, an individual endoscopist should be detecting adenomas. And there are a variety of other kind of suggested QI metrics that have been proposed for colonoscopy. I wanted to talk a little bit more about ADR because it turns out that there's really robust evidence that suggests that an individual endoscopist's adenoma detection rate is directly tied to the post-colonoscopy colon cancer rate. So this was a study published in New England Journal of Medicine several years ago now, where it compared endoscopists who were grouped by quintiles of what their baseline adenoma detection rate is. So the quintile 5, or the high performers, were individuals, endoscopists, whose adenoma detection rates were 33 to 50%. And then the quintile 1 were endoscopists whose ADRs were 7 to 20%. And what we can see is that the individuals with the higher quintile baseline ADR had a significantly lower risk of having a future interval colon cancer. So importantly, actually, adenoma detection rate is actually modifiable. You can teach an endoscopist to get better at detecting polyps, and that actually can improve future outcomes. So in this study, they looked at baseline quintiles of adenoma detection rate, and then looked at individuals who were able to improve their adenoma detection rate by moving to a higher quintile. And what they found was that providers who were in baseline low quintiles, but were subsequently able to improve to the 5th quintile, overall had a significantly lower rate of having future interval colon cancer. So that's why adenoma detection rate is so important for GI endoscopists. Now, unfortunately, adenoma detection rate is not always, adenoma detection rate is sometimes tricky to measure because it requires linking the findings of a colonoscopy to pathology, which often can come a couple of days later. This can be done in a few different processes. It can be manually recorded, or it can be recorded through a variety of IT initiatives. But there are challenges to measuring adenoma detection rate. So I mentioned cecal intubation rate was considered another priority quality metric. The reason this is considered a priority quality metric is because there's data that suggests that for individual endoscopists who get to the cecum 95% of the time, they have a lower risk of having a future colon cancer. Conversely, endoscopists who are not reaching the cecum less than 80% of the time, those individual endoscopists may have higher rates of future interval cancers. And so the recommended targets are 95% of the time for screening examinations, we should be getting to the cecum. And in reality, that number should probably be closer to 99%. Now, if those numbers are lower than 95% of the time, that means that that individual needs to be re-educated and trained. Withdrawal time is also considered an important quality metric for providers doing colonoscopy. And the reason is because withdrawal time has been directly correlated to future colon cancer. So withdrawal time is defined by the time it takes starting once you get to the end of the colon and the cecum and have cleaned the right side of the colon. It's the time that you spend looking while withdrawing the scope. And in this there was a pivotal study that was published in 2015 that found that the lower the individual physician's withdrawal time, the higher rate of interval colon cancers. And this intuitively makes sense because if the withdrawal time is low, that individual may not be spending enough time cleaning and washing the colon, looking for polyps and then removing them. Bowel preparation quality, I already mentioned, is critical in order to achieve the benefit of colon cancer screening. And as I mentioned, the performance target should be approximately 85 to 90%. So that means is at least 85 to 90% of the time, the bowel prep should be adequate to allow for recommended screening or surveillance intervals. So in order to achieve this, we need to think about what bowel prep is the best agent. And uh, as of now, there's really plenty of data that suggests that the recommended bowel preparation should be administered in a split dose format. So split dose bowel preparation means that at least half of the prep is given 4 to 6 hours before the time of the procedure. And there have been several randomized controlled trials that have demonstrated that split dose bowel preparation directly increases the risk increase the ability for an endoscopist to find an adenomatous polyp as well as an advanced adenomatous polyp. So split dose bowel preparation is considered the standard of care. Now, in terms of comparing individual bowel preps, whether it's polyethylene glycol based preps or other bowel preparation preps, there really is limited data on individual comparisons between Miralax or Golightly or Suprep or Movie Prep. But however, whatever bowel prep is chosen, it should be administered in split dose format. Procedural safety is also really important. The risks of colonoscopy can include perforation or bleeding. Those usually occur in patients who have some sort of intervention, but the targets should be, these events should be relatively rare. So perforation should occur less than 1 in 1,000, and more likely less than 1 in 10,000. And then bleeding should occur less than 1% of the time. And in this national insurance claims study, basically they found that overall complications related to colonoscopy are relatively rare. So in this national study, bowel perforation only occurred 0.5 of 10,000. So the rates are relatively rare for perforation. So if perforation is occurring more frequently, that's concerning. And again, that means that we need to do some investigation on why that's happening. So I mentioned that sessile serrated polyps are an increasing cause of colon cancer. Serrated polyps are considered a new precursor for colon cancer compared to standard adenomatous polyps. And they can actually be challenging to detect because they're often flat and covered with mucus on the right side of the colon. And this is another case. So here we have a picture of a sessile serrated polyp. So in this particular case, a 55-year-old man undergoes a screening colonoscopy. I find this lesion here, which is very subtle. It's located in the right colon. It's covered with mucus, and I resect that via endoscopic mucosal resection. The pathologist returns consistent with the hyperplastic polyp. When should we repeat surveillance? So I showed this case to basically show what a typical sessile serrated polyp looks like. It typically is located in the right colon. It has this mucus cap. It can often be very difficult to detect, particularly when this mucus is washed off. But this is known to be a direct precursor to colorectal cancer. This is often challenging for pathologists because hyperplastic polyps, which are typically not considered to be neoplastic, pre-neoplastic lesion, are often very difficult to distinguish from sessile serrated polyps. There's a lot of inter-observer variability between detecting hyperplastic polyps from sessile serrated polyps. And so this makes it challenging to construct a robust quality metric. And in fact, in this study, they looked at pathologists' observed to expected classification ratio. So on the left side, we have just run-of-the-mill adenomatous polyps, and there wasn't a lot of variability between observed to expected classification. However, there was significant inter-observer variability for patients who had serrated polyps. And that's just because it's difficult for pathologists to distinguish between hyperplastic and serrated polyps. So ultimately, I mentioned already that advanced adenomatous polyps, which are adenomas that are greater than a centimeter or contain high-risk pathology features such as villus features, are the lesions that carry risk of growing into colon cancer. Well, why don't we just measure how frequently those are detected and have that be our standard QI metric? Well, the problem is that, first of all, advanced adenomas aren't detected as frequently, and there does tend to be significant variability in endoscopists detecting advanced adenomas. So in this particular study, the advanced adenoma rate was calculated, and it ranged from 1% to 14%, which is a huge degree of variability. So that's just a little concerning about how there's room for improvement in performance of colonoscopy and why quality improvement metrics matter. If we go beyond colonoscopy, I think that there's a lot of room for improvement at every step in the process. So if we start at the beginning, when a patient is ordered a colonoscopy, the question is, well, should we start considering which patients are appropriate for screening? So is the patient over the age of 76? Is screening appropriate for them? Was the appropriate screening test selected? Was a FIT test offered for the patient? Was the patient a better candidate for a FIT versus colonoscopy? For patients who are ultimately undergo colonoscopy, was the bowel preparation adequate? Was a high quality colonoscopy performed? If pathology is if there are polyps that are removed, then at the pathology level, there need to be quality improvement metrics. So are serrated lesions being appropriately identified? And then after the colonoscopy is performed and a surveillance recommendation is provided, is the recommended surveillance guideline appropriate? Is it concordant with guideline-based recommendations? And all of these should be considered with the ultimate goal of reducing colorectal cancer incidence and mortality. So I think there's a lot of work to be done in this arena. So let me just summarize what we discussed. So if we're talking about, what age to start screening patients, I think that we should really prioritize colorectal cancer screening in patients that are 50 to 75. We should be doing a better job of accurately recording a family history of colon cancer, as well as a family history of other cancers, and family history of cancers such as endometrial cancer, ovarian cancer, often increases our suspicion that the patient may have a hereditary colon cancer syndrome, such as Lynch syndrome. So that's why family history is really important. I personally think we should be screening patients in less than 50 who are having symptoms such as iron deficiency anemia, rectal bleeding, etc. And we should be considering screening in patients that are 45 to 50 based on the U.S. Preventive Task Force Service recommendations, although I think that this has its own challenges in that our costs may be going up and we may be deflecting resources away from patients who are over 50 who are higher risk for colon cancer. When we think about what test to order, well, should we be ordering FIT testing or colonoscopy? Well, ultimately, the best test is the one that gets done. However, I think that we should really be considering FIT or colonoscopy as our first line tests and consider Cologuard and virtual colonoscopy as second line options for those who don't want to undergo FIT or colonoscopy. If a patient chooses to have a FIT test done, then it really needs to be done every year because the sensitivity for cancer is not perfect, and it needs to be followed by a timely colonoscopy if the FIT test is positive. For patients who ultimately undergo colonoscopy, then it's important to have a high quality colonoscopy. Otherwise, we're not going to be achieving the benefit of colonoscopy for colon cancer screening. So an adequate bowel preparation with split dose prep is critical to achieve the benefit. And then I wanted to stress that colonoscopy, as I mentioned, is operator dependent. So down the road, patients might be asking their endoscopists, what is their adenoma detection rate? There's been a push in some communities to have publicly available adenoma detection rates so that patients can choose who they're getting a colonoscopy done for. And these are important because the ultimate goal is to really minimize the risk of post-colonoscopy colon cancer, which unfortunately still happens very frequently. So with that, I'll conclude. I'm happy to take any questions. And if there are any questions that come up down the road, please feel free to email me.
Hi, Dr. Sengupta. I'm Shauna. I'm one of the chief residents as well with CHAD. I have a quick question. First of all, thank you for your presentation. It was really informative. But I wanted to get your thoughts about the utilization of mucosal exposure tools like endocuff vision in terms of for adenoma detection rate, if that's improves it or you recommend it for GI.
Sure. So first of all, I think there are a variety of techniques and technologies that we have to improve the adenoma detection rate. So the options to do that include devices that are on the tip of the endoscope to help deflect the folds back. And there have been several studies that have shown that devices such as endocuff or endo-eye can increase the risk, can increase an individual's adenoma detection rate. However, it tends to only benefit providers who are on the lower quintiles. So I personally regard it as a great tool to improve the adenoma detection rate for endoscopists who are on the lower quintiles to kind of improve their ADR to a higher quintile. There's not a lot of evidence that it helps high performers or high detectors already. I mean, that's a great question because there's a lot of technology that's in active investigation beyond just devices like endocuff. So there's a whole kind of field of artificial intelligence in colonoscopy and whether we should be using AI-guided polyp detection. There have been 2 or 3 randomized controlled trials that have shown that AI or artificial intelligence built into colonoscopy helps increase the rate of endoscopists finding polyps. Similarly, it only tends to work in providers who are already kind of not doing very well. So in the future, I think it's probably AI is going to play a role. AI is going to be built into our endoscopes and is going to allow us to find more polyps. And providers who are not kind of hitting a 30% adenoma detection rate may benefit from tools like endocuff and other attachment tools on the tip of their scope. It's a good question.
Hey, Dr. Sengupta, this is Chad. Thank you very much for the presentation. I think there were a lot of quality metrics that were very interesting that just haven't crossed my radar until now. Touching on the adenomatous polyp detection rate as well as your rate of reaching the cecum, are either of these metrics used in kind of the credentialing process or a QI process at a larger scale, at like a national scale rather than an institution-specific scale?
So that's a great question, Chad. So no, not yet. But I think that there's a big push to kind of allow for more national kind of streamlined measurement. The challenge, so cecal intubation rate is important, but the more important QI metric is ADR. The reason that it hasn't been mandated as a part of credentialing is because it's challenging to measure for the reasons that I kind of briefly mentioned, because it requires integration of pathology to the procedural report. So it's something that it's labor intensive to measure. And because of that, ADR has not been considered as part of credentialing or kind of annual public reporting, but that might change down the road as we're kind of improving our ability to kind of link up pathology to procedural reports with techniques such as natural language processing. So for example, that's how we record ADR at our institution. We use natural language processing to basically tie pathology records to our procedural reports. So hopefully, down the road in the next 5 to 10 years, we'll have better, more streamlined ways of measuring cecal intubation rate and adenoma detection rate, and have that as part of kind of credentialing and physician improvement, et cetera. But I think we have a ways to go.
Dr. Sengupta, can you hear me?
Yes.
Thank you so much for a great presentation. And thanks for highlighting to us the pitfalls of colonoscopy. A lot of times we think that we checked the box, we send our patient for a colonoscopy, they had it done, and we're okay for 10 years now. So how would a referring physician, a primary care physician, know that their patient did get a high quality colonoscopy? And the corollary of that, building on Chad's question, is wouldn't having post-colonoscopy colon cancer be an easier measurement of quality, since this can be easily tied from the claims from insurance providers or Medicare that this patient did get a colonoscopy and then a year later, for example, or 2 years, they got post-colonoscopy colon cancer? That probably was a missed lesion in all likelihood. Thank you.
Sure. Great question. Let me answer the first part of that to begin with. So I think that the onus is on the endoscopist and the GI provider to determine when the next surveillance recommendation is due, because that recommendation is dependent based on the quality of the bowel preparation, the individual patient's risk based on their family history, and the findings of the colonoscopy. So I think that it always makes, in my mind, it's a great idea to communicate directly with the provider who did the colonoscopy to determine when is the next recommended surveillance interval. Now, I think for a primary care provider, logistically speaking, it may be challenging to do that, but I think it's helpful to get an idea, and looking at the procedure report, there's certain things that should be red flags. So anytime there's an inadequate bowel preparation, anytime there's a mention of a fair or inadequate prep, that essentially means that the colonoscopy is not adequate for screening purposes and should be repeated within 1 year. I don't think it makes sense to kind of have primary care physicians recommending surveillance intervals, because the literature is changing so fast and high-risk polyps. I really think that should be something that should be recommended by the person who does the procedure. So I think communicating with your GI colleagues is always helpful. The second question was about, well, why don't we just look at missed colon cancer, interval colon cancer as a QI metric? So, I mean, again, that's a great point. I think the challenge is that realistically, although 8% of all colon cancers are considered interval cancers, interval cancer is still relatively rare. So it's not frequent enough to be considered a robust QI metric. Having said that, that is something that all hospital systems ideally should measure. And there have been recommendations on how to categorize interval cancers. So I didn't show this slide, but if an interval cancer does occur, it can occur because either the polyp was not detected, or it could have occurred because a large polyp was resected, but perhaps it was incompletely resected, or it could occur because the bowel prep was inadequate, but the patient was told to come back at an inappropriately late time. So there's a lot of literature on the fact that we should start measuring overall interval colon cancer rates and should categorize them, but it's just not frequent enough an outcome to be considered a priority QI metric.
Great. Thank you so much. There's no other questions from our audience. I don't think if there's any other questions from our Zoom participants, please feel free to ask. Otherwise, we will wrap it up, and we greatly appreciate your expertise and speaking to us today, Dr. Sengupta.
Thank you so much. And feel free to, if there are any questions that arise, feel free to email me or send me a tweet.
Great. Thank you.
Thank you. Bye-bye.